In this video today, we're going to talk about an injection into the face, why you should consider this if you have severe pain. If we haven't met, I'm Dr. Orlando Landrum. I'm a physician that helps patients understand their options. There are options for pain relief, there are options for improvement in their mood, there are options in functionality and how to be able to live your life in a better way and enjoy the things that you want to enjoy. Today, we're talking about ways to be able to improve facial pain, headaches, and how that's impactful for mood. If you haven't heard about a specific treatment before called a sphenopalatine ganglion block, that's what we're going to talk about. A lot of fancy words. When I ran it through the computer and looked at AI and saw what was the level of interest, it was 0. And the reason why is because most people don't know what a sphenopalatine ganglion block is. Fortunately, for those of you who are watching live or watching this at a later point in time, after 2 to 3 minutes of this, you will know exactly what it is. So let's go and show a little bit of anatomy. For those of you who haven't seen this before, you can see this picture that is a cartoon that looks at a portion of the brain, the cerebellum, the spinal cord, and the nerve roots that come in. All of these show the types of nerves that this type of procedure impacts. We're going to use different articles to explain exactly what is done and how it can be able to be helpful. So one of those articles is the following. It's an article that looks at sphenopalatine ganglion blockade and headaches and how this is potentially useful. As you can see, it's published by American Headache Society, and that looked at what was useful for people. And what they found was the following, is that the top diagnosis for which this actually was helpful was for migraine, something that's called status migrainosus, which is basically headaches that just do not stop. Then they talked about episodic migraine, episodic cluster, and then chronic cluster. So what the heck is cluster? Because it doesn't necessarily sound that flattering. So cluster is a type of headache that's focused predominantly in the orbital region of the eye and is piercing, it's lancinating, it's something that is severe in nature. How the way that cluster headaches work versus traditional migraines are thought to be widely divergent, that they are not one and the same, that they are completely different. And the reason why this is important is it tells us that this type of treatment may be able to give us benefit for different things besides headache alone, and it certainly does. And a little kind of sweeten the pot for those of you who are joining us live or watching us at a later point in time is maybe we can even do this and don't need a needle, which is a big plus. So when we talk about what this type of procedure entails, this paper kind of shows us that. So non-invasive sphenopalatine ganglion blockade and what's done or what has been done before in the past in order to be able to make that work. And in essence, it's a procedure that looks like this, where you use a type of device that goes to the nose, as opposed to us going into the face or a needle going into the face. The specific device is something that's called a TX360. It's been out for probably greater than 5 to 7+ years, and it targets an area that is present, that's in and around something that's called the turbinates. So those of you who've had either sinus surgery or know about the sinuses, it looks something like this. And those sinuses, this is the inside portion of the nose, are areas where you have this middle nasal and you have components of the inferior nasal elements, and then you have something where you see this little circle. And this little circle is an area called the sphenopalatine foramen. So that's really easy for me to say. And I know I'm using fancy words that seem super like sciencey, but at the end of the day, it's an area where there's a collection of nerve that's collected to the brain that historically we used to take a needle, not through the nose, but actually through portions of the face to be able to reach it. And that was done as early as the, I want to say 1900s or so, is when originally SPGs were originally utilized. Okay. So at the end of the day, here we go. So it's first described in terms of the actual anatomy in 1749, and the first procedure was done in 1909. So greater than a century or so ago is what they were doing. And the way historically it's been is using x-ray in the past, where you can see these needles that come in. This looks like it comes through the nose, but it's actually just a little bit different to target that area in that region. Well, no one really loved that, right? So most people are like, well, how can we do this and make this a lot more tolerable? And then how can we make this work better so that it's less painful and it's less problematic? So one of the ways to do that is using that type of device that I described before. And what it does is it comes in, and you can see this picture in the top left-hand portion. It comes in through the nose, and it's directed in an area that tries to reach that portion that gets back into that region in the medial aspect, meaning kind of towards the middle or center. And we target it with the straw, a straw. So it's not this needle poke, painful thing that's just going to be challenging. What are some of the side effects that are associated with? Some of the side effects are the following: is that you can have some degree of nauseousness. You can have a little bit of bitter taste from the aspect of the anesthetic. You can have some lightheadedness, and you may have some numbness in the back portion of your throat or the pharynx, right? So there have been ways that they've done this by doing it in an invasive way, but using modern technology. So what was being done is different types of treatment. And this is another paper, if we're using the fancy reading of it, it's something that's called ultrasound guided suprazygomatic nerve block to the pterygopalatine fossa, right? And the way that they were doing this, without making you guys too like, oh my, graphic, it looks like the following, where they use ultrasound, and they use ultrasound to be able to see that arch and see the nerve, and use a smaller needle to be able to pop down into that area in a safe way and place local anesthetic. A lot more uncomfortable in some ways than this treatment like this, but there are reasons for why you would consider doing that. And what they were able to show after looking at different dynamics of this is they were able to see that basically this is your needle orientation and depth when you do it in that way. You're reaching the same area, but as you can kind of see, the picture on the left is as if someone's facing you. The picture on the right is if you're actually looking at them from the side. And the picture down below is if you're looking from underneath, and you can see where the depth of that needle is going. In essence, if you were to take this picture on the far right and take a look at where we're going at to the nose, we're getting at it from the other side, and we're letting that medication go through osmosis to that area in that region. What this paper was able to kind of show is that type of approach was able to get close to that area that we talked about before, that sphenopalatine ganglion. And the advantage is historically it's been useful for being able to provide value for migraines, unremitting migraines, and cluster headaches. So most people would say, well, you know, there's new medications out there, things other than sumatriptan, things like this calcitonin gene-related peptide that has been present, CCGRP, right, that's been out there, that's really been useful. Well, it doesn't work in everybody. And so using this in combination with some other techniques, particularly those of the occipital nerve, has really been successful for a lot of patients to be able to improve treatment-resistant headaches that haven't responded to traditional medication. That's one of the reasons why we broker this conversation. So are there other treatments besides just the utilization of local anesthetic? Yes, there are, and they have been done. And so those things that you can see are things like radiofrequency and neuromodulation. We've talked about that before. So what does radiofrequency entail? In essence, it entails using a potential type of needle that isn't targeted at the site, but it's using heat to be able to target that aspect of the nerve root. And neuromodulation is a way to be able to improve this so that you can get relief, as you can see here in this fifth line, that can last as long as 150 days. So we're talking almost close to 5 months or so, right? And when we talk about being able to give someone relief of headaches for 150 days, that's pretty darn significant for you not needing invasive surgery or having to be reliant upon medications. So what are some of the other kind of progressions of this? Is to be able to say, how well is this working across different patients? And what they've been able to see is that it's been useful not just for headaches, as I mentioned before, but things like trigeminal neuralgia and things where you have pain after having sinus surgery or having problems with nasal operations or head or facial pain or cancer related to head and face, where it's been able to give pain relief, which has been significant and has been sustainable. So at the end of the day, it's a treatment option for patients that isn't really well known, but targets a specific nerve cluster that can be able to improve pain. And now we're thinking maybe it has some other value. So one of the things is for those people that have had post-concussion headaches and things of that nature where they've had CTE, whether this may be a utilization that can provide benefit. And they've had papers that have shown this as such. What we're interested in is how this might also impact not just physical pain, but mental as well. And using this in a non-invasive way without the needle. Historically, they had been, probably in the last 20 years prior to the straw technique, using something that's called pledgets, where you take kind of these Q-tips and you kind of dose them in local anesthetic and you stick it up the nose and you hold it there, which was challenging, annoying, and just problematic. But now to be able to use that straw technique or using ultrasound guidance or the two in combination, if you had to, you can be able to help patients get them back on their feet, help them punch pain in the face and get back to leading the life they deserve. New tip, new trick for an old type of solution that's been out since the 1900s, a different perspective on how to be able to get those things of an improved quality of life. For those of you who joined us live, we appreciate it. If you have questions, submit them. For those of you who joined us at a later point in time, please also submit your questions. We really appreciate you giving us a thumbs up. And if you're new to the channel, please subscribe. Let us know what things you want to talk about and how we can be able to help you going forward in the future. Thank you so much and have a great day.